discrimination that may exist where people do not have access to this type of health services for different reasons, whereas access really refers to physical access. Are people able to get to the physical health facility, for instance? Do they have the means to pay for transportation to access some of these services? And then finally, we want to ask, are there any financial barriers that exist to accessing these health services, which is what affordability refers to? Can people afford these services, whether it's medicines or treatment or dietary? And are there existing financial structures that exist to be able to provide or support this affordability? For instance, are there any national health insurance funds, or is there a social protection program that exists to be able to support with some of these health expenses? Next slide, please. And so I wanted to highlight these principles when we think of, so in addressing these three barriers to accessing health services, it's important to keep in mind these principles during any sort of response analysis or any sort of planning for health interventions. And health interventions can come in wide ranges that may address availability or accessibility of health services. So the universal health coverage states generally it's a principle within any type of crisis that essential health services should be provided free of charge at the point of service, particularly in emergency or humanitarian crisis. This is really important that refugees or IDPs or people who are in need should not have to pay for any of these services, including both primary or tertiary health. However, we know that this is not always the case. There's always reported expenditures. As you all know, people always report that they're paying for health services, whether it's directly paying for user fees or indirect, so paying for transportation, for instance, or some care is not covered. So primary would be covered, but then medicine is not covered. So keeping that in mind as well, it's important to also note that health needs are very different, or responding to health needs are very different than responding to other sectoral needs, such as wash, for instance, or food, because you cannot really, health needs are quite unpredictable and they can't really be quantified. You can't really break it up like you do food, for instance, in a minimum expenditure basket, or divide a portion among a household or a community, because they're quite unpredictable. There's different layers of health needs, like primary, long-term. So it's also important to keep that in mind when thinking about the response options. Next slide, please. I keep coming back to these three: availability, accessibility, and affordability, because I think it's really useful to be able to think about how we want to respond to health needs. And I think it makes it much more easier to understand when we talk about health response options. So health financing includes whether or not, as I noted earlier, whether or not these services are available. So the aim of health financing, the objective, is to provide some sort of some support to accessing these essential health services, making sure that these health services are available. And that's the optimal response. That's the first response. We need to make sure that there's health services available and people, the financial barriers, for instance, which we discussed earlier, and strengthen these services. Then we can think about other financial barriers, such as providing. This is where also CVA has the potential to really influence or really support access to health services. So once we've kind of addressed the the available health services and access, then we want to figure out how can we improve the access to people to be able to get, go to these services, whether it's issues of transportation or issues of accommodation. And again, this is where really has the potential to influence. Next slide, please. Thank you. And so I've broken up the health financing into two response options. And this, we have this in our working paper from the Global Health Cluster cash testing. And so if we want to think about response options, we can think about supply side response options, which really relates to availability and access, and demand side response options, which is more related to utilization of services. And I've listed out what supply side response options can refer to. It can refer to coverage under a national health insurance fund, pooling of funds, for instance, or purchasing services from providers to deliver these services, which is what, for instance, some of the mobile clinics are. And I think this also exists. I mean, a lot of times in emergencies, you see this is how provided. The demand side response option is where practitioners can really influence, for instance, providing, and where we can reduce financial barriers, where we can provide vouchers for health services, for instance, as we'll see in the Bangladesh case study, or we can reimburse costs of services, whether that can be conditional, unconditional cash for some of these services, or using some of the multi-purpose cash to address some of the indirect expenditures related to accessing health service. But I do think it's important to highlight that the optimal response should be related to supply side response option, so as not to encourage any culture of user fees. So you should explore all options related to reducing these user fees before going into exploring how to use cash and vouchers to address some of these financial barriers. Excuse me. Next slide, please. So what is the potential of cash and vouchers as it relates to health? So cash and vouchers can really improve access and utilization of health services. Utilization because it can impact, especially conditional cash can really impact behavioral change, for instance, and utilization. It's to, giving people the resources, the financial resources to access these health services, whether again, it's paying for user fees or indirect costs related to transportation. But I again reiterate that when health services are available, provider payment mechanism should be the optimal, and then CVA can, for instance, setting up a mobile clinic, but if there's issues with transportation, then providing cash to be able to access that mobile clinic. And then finally, cash cannot solve any supply related issues, which I mentioned previously. Next slide, please.
So Yasmin, I'm just jumping in for a second because every now and then you cut out. So maybe just go very slowly and clearly, or maybe turn off your video while you're doing this, because we'll look at the presentation.
Okay, thank you, Julia. I'm sorry about that. So the current evidence on CVA. So there is a gap and there is a shortage of evidence on CVA in health. And that's partly because it's not that it's not done, but it's unfortunately not well documented. But evidence shows that CVA can really contribute to health outcomes. We've seen this in several studies and several globally in all the regions. And even within, so there's a lot of CVA in health happening on the development side. And I think there's an opportunity for us to learn from the development programs. So there's no reason not to take from the evidence from the development programs and try to apply it to humanitarian settings. CVA also has the most impact when it is coupled with something else, which is the case for all CVA programs. CVA alone will not always resolve the challenges that it attempts to resolve. CVA can work as an incentive for behavioral change. Interestingly, cash and vouchers can also create competition among providers to ensure quality. So for instance, if a program is provided to one hospital where they're receiving money to reimburse for user fees, then there will be competition among hospitals to receive that contract from the provider based on the quality. Next, please. Can you hear me okay, Julia? Is it better?
Yeah, it's a bit better now. Yeah, just go slow and go slowly, I think, very clearly and slowly. It'll help.
Okay. So I'm just going to go again. So that's kind of the concept of CVA in health. We're hoping to produce more related documentation to make these concepts much more clear to cash practitioners and to link better CVA with health. So now I have the pleasure of introducing these 3 case studies by which we have our panelists. From Jordan, Bangladesh, and Burkina Faso. Next slide, please. So the first case study from Jordan, and again, these case studies are in the Jordan case study has been published. The other 2 case studies are in the process of being published, and we will share these in the coming days. So as some of you perhaps know, the context of Syrians in Jordan, when they first arrived, they had access to free healthcare. However, unfortunately, due to some financial constraints, Syrian refugees had to pay the Jordanian amount, which is what Jordanians were paying. So they were treated as Jordanian citizens with the context of paying for these health costs. So they were accruing high health costs, and a lot of it was coming out of their, out-of-pocket expenditures, which posed a barrier for them in accessing health services. So Medair's intervention was, the response option was in like 3 parts of it. So they provided unconditional cash transfer linked with a specific health need targeting pregnant women that are unable to cover their either natural or cesarean costs. And again, this was very, very targeted for pregnant women. Another component was conditional cash transfer that was used to incentivize, used to encourage people to go, including these pregnant women, to seek services from health service providers related to antenatal care or non-communal diseases. And then finally, so this was kind of a little bit more complicated, was when there's an emergency or acute health need that someone needs immediate support to address this need, Medair explored and provided reimbursement of this service emergency need from a pooled fund. And so 6,892 refugees were targeted in this response, and you can read more about it in the case study. Next slide, please. Thank you. So the case study from Bangladesh is, so Jordan was more of an emergency response, whereas the one from Bangladesh is more development. And vouchers are not new in Bangladesh. They've been used for a long time by different actors. And I think this is also where an opportunity for us as for the humanitarian community to learn from the use of vouchers to address to address barriers to accessing health services. So it was implemented in 10 municipalities across Bangladesh, and a large number of people, 80,000 vouchers. 80,000 vouchers were distributed to 10 municipalities and implemented by 3 organizations concerned with Sajida Foundation, DAM with Christian Aid, and Resource Integration Center. And the response was because there were the poor communities were having, they had high user fees, and they had distance barriers in accessing some of these services, which led to either postponing receiving treatment or relying on negative coping mechanisms. So these vouchers were provided to address these health gaps for the urban poor. And they were done where the people take the vouchers to the hospital, and then the hospital reports the bills to these organizations, who then reimburse the hospital. And then finally, the last case study from Burkina Faso. Next slide, please. Was to address, so it's more related to access and physically accessing nutrition centers for children. So the cash was provided to adults to accompany these children to receive treatment for malnutrition. So 23 children were targeted. And I think what I like about this case study is it's very straightforward in terms of what it will address. It is addressing directly the transportation issue. And there was actually an improvement in attendance of these centers because the transportation was an issue, which resulted in a reduction in the mortality rate for cases of the severe acute malnutrition during the cash distribution period. So I'll stop here, and I just wanted to make sure the sound is still okay before I proceed with my questions to the panelists.
Yes, it's actually been much better. Sorry, we can't see you.
Yeah, no, sorry that my internet is not great. Okay, so I have some very exciting questions for our panelists. So my first question, and please mute unless you're speaking. So how did you decide on your specific cash and voucher modality choice? What factors did you think about? What influenced your response analysis? And I will start with Lou from Medair.
Hi there, everyone, and thank you very much for the opportunity to talk about Medair's programming in Jordan. So to answer your question, Yasmin, how do we decide upon the modality of choice? So as with all things, understanding the context well was number one. So as I'm sure many of you know, Jordan is a context that has well-functioning banking systems. It has existing financial transfer mechanisms. It's a very familiar tool which is used by the Syrian and non-Syrian refugee population, as well as vulnerable Jordanians. And we have relatively robust local markets and a high capacity to increase and preserve supply. So all of these things combined, of course, sets the context for CVA in Jordan in general. In terms of really looking to how we would bridge the gap in access for healthcare for really vulnerable individuals residing in Jordan, a lot of it just comes back to really, again, understanding the structures that are in place. And for us, it was very important to not create parallel systems. So in Jordan, there is a functioning health system through the Ministry of Health. And that it functions but in terms of access to that, the financial barriers actually, Yasmin, you mentioned earlier that Syrian refugees were charged at Jordanian rates. Actually, for a very long time, they were charged at foreigner rates, which is 4 times the cost of what the care should be if they were charged as refugees when they originally entered Jordan. And so they are prohibitively high for most, let alone for those who don't have an income or any livelihood. And so that has ebbed and flowed a little bit in Jordan, and really understanding the context and the changes as they have come has been really important. But initially, the kind of decision to take on the Cash for Health approach in 2015 was as a result of recognizing that actually creating a parallel system, for example, of health clinics, or some other kind of health structure, was not going to help the situation. There was an existing mechanism there available, and the access issue was financial in nature. And so that's where MEDES stepped in to try and bridge that gap for vulnerable communities here. So to answer your question, it's around context and really understanding that, and understanding the structures that are already in place. And that took a long time in terms of assessment to really understand the level of service provision, the access required for beneficiaries that reside. We're working with urban beneficiaries, so they reside across multiple different governorates of Jordan. We aren't working with camp-based. So that, again, makes a difference to the modality that we chose. And then really understanding that and keeping abreast of that to enable us to change our response modality as we went as well.
Thank you for that. So can we hear from Dr. Nikem? I think, Elodie, you might be helping us with translation, correct?
Yeah, so, donc, Dr. Nikema, la question pour vous, pour le cas du Burkina Faso, c'est comment avez-vous décidé de la modalité du transfert monétaire? Donc, dans le cas du Burkina, ça a été du transfert conditionnel restrictif pour le transport. Et quels facteurs ont été pris en compte, en fait, dans votre choix? À vous.
Ok, merci beaucoup et bonjour à tout le monde. Merci pour la parole. Bon, concernant le Burkina Faso, notre intervention a concerné beaucoup plus la partie Sahel du Burkina, qui est en même temps une zone où la sécurité alimentaire se posait énormément, et en plus, le problème d'accès aux services de santé à certains moments de l'année se posait. Par exemple, si on prend la période de la saison hivernale, la plupart des formations sanitaires sont isolées avec les mares qui sont remplies. Alors, et comme c'est la période où le nombre de cas de malnutrie aiguë sévère augmentait, ben, la question était de savoir pourquoi les enfants n'arrivaient pas dans les centres de santé de référence. Donc, par la suite,
je vais juste vous couper. Je vais traduire en anglais, en fait, avant que j'oublie. Donc, just for the translation of what Dr. Nikema was saying is that in the case of Burkina Faso, so the intervention area was in the north of the country, in the Sahel region, where food security is actually a huge concern, but also in terms of nutrition and health, there are problems of accessing nutrition services and health services, especially during the rainy season. So what happens is that during the rainy season and a little bit after and before, some treatment centers are very isolated. So basically the logic behind this intervention, Cash for Transportation, was what was the main barrier? Why children with acute and severe malnutrition were not arriving at the treatment center? À vous.
Je peux poursuivre?
Oui, allez-y.
D'accord, merci. Donc, au regard de la situation, il y avait la Croix-Rouge burkinabé qui avait fait un répertoire des mares et essayé de réfléchir avec les autres comment on peut mettre tout le monde, c'est-à-dire les collectivités, c'est-à-dire les mairies, les populations et les services de santé à contribution pour pouvoir aider les populations vulnérables à pouvoir traverser les mares. Donc, c'est là qu'ils avaient payé des pirogues pour remettre à des particuliers, mais cette expérience aussi n'a pas beaucoup marché. Alors, donc, il fallait maintenant...
Pardon. Je vais traduire juste cette partie-là. So basically what they did is that, so they coordinated with different actors there, including the Red Cross, and the Red Cross did a mapping of the different rivers and also the swamps during the rainy season, and where people have access to health centers or not. And they also coordinated with the local authorities to try to find a solution. And the solution, temporary solution that they found at that time was to provide some sort of canoe to transport people, but this solution did not really work. Je vous laisse la parole.
OK, donc par la suite, ben, nous, on s'est dit, est-ce qu'il n'y a pas lieu d'aller vers les populations pour échanger et avoir une idée de leurs difficultés? Donc, au terme de cette petite évaluation, on a constaté qu'il fallait un accompagnement. Et l'accompagnement ne pouvait se faire que sur le plan monétaire. Faire en sorte que les familles qui ont des enfants malnutris et qui sont référés dans les centres de santé de référence puissent effectivement venir en déboursant un peu. Et une fois qu'ils arrivent au niveau de la formation sanitaire, ils sont pris en charge médicalement sur le plan nutritionnel, et au terme de leurs soins, on les rembourse leur argent qui coûte autour de 5 000 francs pour la traversée de la mare. Mais la seule difficulté, c'est que des familles peuvent avoir à traverser plusieurs mares, comme d'autres auront à traverser une mare. Donc, voilà un peu la situation qui se présentait. Et ce n'était pas aussi évident ni simple pour nous, mais on a essayé quand même, et on a constaté que de plus en plus, les populations avec leurs enfants malnutris arrivaient à adhérer à notre approche, et on a constaté une augmentation quand même de la fréquentation des cas référés au niveau du centre de santé de référence.
Ok, je vais traduire ça. So maybe just to summarize what has been said. So basically, because the transportation, the canoe that were made available for people didn't really work. So basically, they went back to the communities and asked what were the main barrier, basically, to go to the referral center for malnutrition cases. And so basically, they realized that the financial barrier was clearly one of the top barriers. So they realized that providing cash, or at least reimbursing the cost of the transportation by canoe, because the canoes were still there, but they had to pay for it. So reimbursing at the point of service, so at the treatment center, was probably the best option. So that's why basically the modality chosen was conditional. So they had to go to the center, and then they would get the money back. One of the difficulty though was, so for some families, they were a little bit further, so they had to cross multiple lakes, whereas some other family just had to cross one, but the amount reimbursed was the same. However, they realized that at the end of the pilot project, there was clearly an increase in terms of attendance at the treatment center. So it seemed that people, despite the fact that sometimes the amount was the same, whereas they had to cross multiple lakes, they were still coming, and more compared to the year before. So apparently like the distribution of the cash really helped in terms of increasing the attendance. Est-ce que vous avez d'autres choses à dire, Dr. Laurent?
Bon, pas grand-chose. C'est pour dire qu'une telle approche nécessite quand même une petite logistique derrière, un ensemble de suivi, évaluation également par derrière, et bon, des cadres de rencontres périodiques pour pouvoir évaluer quand même la mise en œuvre, le niveau de satisfaction des patients avec leurs enfants malnutris qui sont venus. Donc, voilà un ensemble de choses qui, mis ensemble, bon, faisait l'intervention que nous avions menée.
So basically, looking back, so there are a number of things that from this pilot they learned, and so piloting cash for transportation requires a certain system, monitoring and evaluation, of course, logistic, financial. So it's not only like reimbursing the cost at the point of service, it requires like much more than that, a whole system. So this is one of the lessons learned. Thank you.
Thank you so much. And now I'm going to give it to my colleagues in Bangladesh, Mr. Amran, Dr. Mukhlis, and Dr. Mohammed.
Okay, so if I'm allowed, let me take this chance. So the country, Bangladesh, after independence since 1971, the urbanization was increasing. So if I give you some data, like 71, the urbanization was only 8%. So now it's having 39%. And we are expecting then in 2041, the country will be 50-50 urban and 50% rural. So the country is also having GDP progress, GDP growth, 8% per year. So that means economic progression is happening. New mega projects are taking place in the urban areas. That lot of pull factors are creating opportunities, jobs, and people are coming to the urban areas. But when we talk about this extreme poor, so they are the deprived. In Bangladesh, in the rural area, we have very much structured health system. But when it comes in the urban areas, so majority of the services are not well structured. That means, I mean, the primary healthcare services, secondary and tertiary facilities, these are not well communicated, or referral system is not that systematic. So in the urban context, most of the service providers are either tertiary care or NGO service provider or the private sectors. So this is happening in the urban areas. From particularly this experience of working together with this voucher-based program, so we three of us, three of our organization, Concern Worldwide, RIC and DAM, we try to showcase some of the evidence that we did not go for the big city corporation, but we tried to go for the smaller municipality town or secondary municipality town. That how the extreme poor situation can be taken care of, and the health voucher particularly, how this system can help them from further exposing to the catastrophic situation. And we tested it from our colleague from RIC and DAM, they will add more. So three cases, actually, we tried different approaches. So the voucher, so which modalities we can implement the voucher. So it could be paper-based, it could be very smart card-based or digital system-based, or it could be both mixed. So these three experiences gave us enormous internal learning opportunities and knowledge at the same time. And this learning and knowledge surely will be helpful for the government to take next steps. So I'll stop there. I'll welcome our colleague from DAM and RIC if you'd like to add a few things. Thank you.
This is Mukhlis Ruban from Dhaka Hasani Mission, and I am expressing my sincere gratitude for giving me the opportunity to talk in this very vital issue. Can you hear me, please?
Yes,
so as already Imranul Bhai already mentioned that, and presented some data regarding the urbanization and the poverty related. I would like to focus on poverty related, as you already know that the present growth rate of population in Bangladesh is 1.3%, but in urban it is more than 5% due to rural to urban migration and another pull and push factors. But the poverty is remain for the poor and extreme poor people. The condition is very vulnerable. They are migrated from rural to urban, but they are put into another vulnerability, especially in health, because health facilities are there, but they have limited access, especially the poor and extreme poor and socially excluded people. A study shows that only a third of the women who are living in the slum area, they just receive one ANC, and only 29% women received ANC from and completed 4 ANC according to WHO suggestion. This is the scenario. So from this point of view, and we choose the service package, and this service package also based on the ESD service package we identified and provided for the poor, extreme poor, and socially excluded people. And for the basis of SDG principle, leave no one behind, we actually consider the leave no one behind approach and included the poor, extreme poor, and socially excluded people in our project purpose. We also considered the government others commitment also and others priority, which we already mentioned in urban health strategy in 2030, as well as the city corporation law, city corporation law, where mentioned that the urban poor health facilities will be the responsibilities of local government, especially the municipality. So from this viewpoint, we included the city municipality in our project. So we can say something from risk in this aspect, and we'll come again next course of action.
Thank you, Mukhlesh Bhai and Imran Bhai. As stated, Imran Bhai and Mukhlesh Bhai, urbanization in Bangladesh go very fast, but there is no infrastructure developed in the same times from government and also from NGO side to serve the urban poor people, especially to provide primary health care and also emergency maternal and child care. Rick has a long experience to working with urban primary health care project, and based on the experience, Rick choice the modality to serve the poor people through this CVA modality, and can perform to serve the poor people within a very short time and with quality. By engaging the local clinics and also the municipal authorities in respected 6 municipality area in Bangladesh. Can you hear me?
Yes, we can. Yes.
Yes, we can.
Yeah.
Yeah, thank you, Nasir bhai, and thank you, Mukesh bhai. So these were the conditions actually how the country and particularly Bangladesh are trying to implement this health voucher projects in urban context. Over to you, Yasmin.
Thank you so much. And again, the case study is really useful because it outlines the design and implementation of this pilot project, which I think would be really useful for humanitarian actors, particularly in assessing the quality of the health service providers that should be sought, how to contract them, and what are some monitoring systems you want to keep an eye out for during the design of these programs. So my next question is to my colleague, Dr. Nikema, and this is more related to the implementation for projects. Really.
Yasmin, sorry, you broke up. Can you say that again? The question was related to.
Nikema. Can you hear me?
Yes.
Okay. So for those who want to implement a similar project, reducing financial barriers to accessing healthcare, so for instance, cash or vouchers for transportation or for indirect related costs, what would you recommend in thinking about the potential risks, particularly if it's cash, for instance? I guess in your case, it was conditional cash. But if we want to implement something similar, what are some things we need to think about with potential risks? Elodie, did you hear that?
No, I'm sorry, I didn't hear the question. It cut out. Can you just repeat maybe the last sentence with the question?
Okay. Okay, I apologize for my internet. So the question's related to what are some things, if we want to implement a similar project for some of our participants who want to implement a similar project related to reducing financial barriers and reducing indirect costs related to accessing these health services. What are some things we need to think about with regards to potential risks, such as, for instance, such as, particularly if it's not conditional, perhaps there's some risks of misuse or, yeah, what are some risks that we want to think about if we were to design and implement something similar?
Okay, so let me just translate that. Dr. Nikema, donc une question pour vous encore. Donc en fait la question c'était par rapport en fait aux leçons apprises et aux recommandations et surtout en fait si vous avez des choses à recommander dans la gestion des risques liés à l'utilisation des transferts monétaires et en fait des exemples qui ont été fournis dans les risques, c'est par exemple l'utilisation contraire aux objectifs du programme de l'argent. Donc est-ce que vous avez en fait des recommandations par rapport à ça, comment est-ce que vous avez géré ou réduit en fait ces risques-là et puis voilà, peut-être des recommandations aux autres qui songeraient à faire quelque chose de similaire.
D'accord, merci pour la parole. Bon, par rapport à l'ensemble de ces questions, bon, je pourrais dire ceci. Premièrement, c'est faire une étude assez fournie sur la situation de la zone d'intervention. Parce que nous, notre zone, à un certain temps, il y avait les mares, il y avait l'insécurité alimentaire, mais maintenant, il y a l'insécurité, même au vrai sens du mot. Donc, vous voyez qu'il y a de nouveaux fardeaux qui viennent encore alourdir la situation. Donc, il faut en tenir compte pour voir est-ce que la capacité de financement dont nous disposons là permet de pouvoir faire face. Parce qu'au-delà des mares, bon, comme il y a des formations sanitaires qui sont fermées, surtout aujourd'hui, liées à l'insécurité, bon, qu'on connaît, et en plus, il y a d'autres formations sanitaires qui fonctionnent à minima. Donc, vous voyez que la pression risque d'être très élevée pour que la femme ou la maman quitte avec son enfant malnutri pour pouvoir avoir accès à un centre de santé, d'abord fonctionnel, et ensuite pouvoir arriver au centre de santé de référence. Donc, vous voyez que ça nécessite une budgétisation conséquente. Bon, tenant compte bon, des risques de dépenses que la maman va faire. Donc, ça, c'est
Pardon, je vais juste traduire la partie sur l'insécurité et après on pourra parler des autres risques. So basically in the intervention area, insecurity is very high. So this is something that was very much in the design plan, because what they did is that they had to do a very thorough insecurity and also just context analysis of the situation, because there are also some treatment centers and health centers that are closed because of insecurity. So that was definitely something to take into consideration. And what they did on top of the analysis of the context was to have sufficient funds basically to manage the risk. Insecurity risk. Docteur Nikiema, à vous pour la suite.
D'accord. Donc, je dirais également que par rapport à cette situation, bon, il faut qu'on arrive à bien faire la sélection. C'est ce qu'on a pu apprendre. Parce que en temps bon, où il y a les mares qui empêchent d'arriver, maintenant, comme il y a d'autres nouvelles situations, ça suppose qu'il faut enrôler. Bon, certaines personnes qui, en temps normal, n'étaient pas éligibles, bon, je sous-entends, c'est ce qu'on appelle les personnes déplacées internes, les PTI. Et parmi eux, il y a des enfants qui vont être malnutris au regard du fait qu'ils se sont déplacés liés à l'insécurité. Donc, il faut pouvoir arriver à les répertorier bon, dans une liste et en tenir compte. Également, il faut qu'on parte du principe qu'il faut justifier l'argent qu'on remet aux parents ou à la maman de l'enfant malnutri. Maintenant, si pour X raison, elle n'a plus de document d'identification, on fait comment? Donc ça aussi, c'est des questions auxquelles il faudrait qu'on se prépare chaque fois à trouver une flexibilité et pouvoir sauver la vie de l'enfant. Mais en retour, il faut qu'on arrive quand même à pouvoir justifier. Donc, vous pouvez traduire cette partie, puis je continue.
Oui, alors, so just to summarize, so basically another way of mitigating some of the risk was to have clear selection criteria and have beneficiary list, because in that area too, you have a lot of IDPs. And amongst these IDPs, there are families with children with malnutrition, of course. So it was very critical in that case to have beneficiary list. IDPs were included in the program. There was no difference. So basically it was, but however, it was still very important to have a list of the beneficiaries in the villages targeted, but also potentially the list of names for the IDPs who would have access to this project. À vous, docteur.
D'accord. Donc, bon, au regard de toute cette situation, il a fallu qu'on crée des cadres bon, à l'échelle village et même à l'échelle du système de santé pour échanger sur l'ensemble de ces problématiques et trouver l'approche qui semble être consensuelle au moins à minima pour pouvoir aider quand même les mamans qui ont des difficultés avec les enfants malnutris à pouvoir avoir accès aux centres de santé. Et ces cadres de réflexion aussi, bon, consomment un peu de temps et ça regroupe un certain nombre de personnes venant de différents secteurs de développement pour pouvoir chaque fois refaire le point, arrêter de nouvelles stratégies et proposer de nouvelles activités.
Okay, so another mitigation measure was actually to go back to the communities and to the beneficiaries from time to time, just to be able to adapt also the project and the transfer component, cash transfer component, just to make sure that help was still responding to the needs and the risk were reduced, mitigated. Voilà.
Bon, donc, je pense que c'est l'ensemble de la situation comme ça, même si on voit qu'il y a certaines mamans, une fois qu'elles sont dans le centre de référence, pris en charge, au moment du retour, au regard de l'insécurité, certaines ne veulent plus retourner. Donc ça aussi, c'est également une autre difficulté. Et on est obligé peut-être de voir au niveau des camps des personnes déplacées internes pour pouvoir les placer là-bas et les donner le minimum possible en attendant que la situation sécuritaire s'améliore pour qu'elles puissent retourner dans son village.
Okay, so it was very important to be flexible enough and to adapt to the situation, because sometimes like a mom will come to the center but will she would not want to leave the center because of insecurity. So it was important also for help to be flexible enough to provide temporary accommodation or temporary arrangements so the mom could stay somewhere. And they did the same thing for IDPs, so trying to find temporary solutions so then they didn't have to travel back, to insecure areas.
Donc, on se disait que peut-être pour conclure, le cash transfert, ça aide à améliorer et à faciliter, mais seulement pour l'enfant malnutri, on va arriver à régler le problème. Mais la maman qui a laissé d'autres enfants au village est sous une pression psychologique qu'elle veut s'occuper de cet enfant malnutri. Elle veut également penser aux autres. Donc, finalement, le risque est qu'à son retour, si elle a la possibilité de retourner avec les conditions sécuritaires, d'aller retrouver que d'autres enfants sont malnutris et le risque de revenir. Donc, vous voyez que ça devient comme un cycle qui est là, un cycle vicieux. Ce n'est pas aussi évident ni aussi simple que ça, quoi.
Okay, so maybe to conclude, basically, yes, sometimes because of insecurity, so parents will not want to come to the treatment center, or they would not want to leave, and so on. So it was, it could create a vicious circle. And the help will in that case will not achieve some of the objectives of the project. But so this was something of a concern for them, this vicious circle. But they really try to monitor the effects of the cash, so then the risk, the potential risk, were at least reduced. I think that's it.
Yasmin, we can't, I know that you've moved to your hotspot. We can't hear you at the moment.
I was on mute.
Oh, no worries. And speaking panelists, please put your camera on so the audience don't stare at black squares. Yasmin, to you.
So I switched my internet, so hopefully you can hear me better now. Again, I apologize about my internet connection. Thank you so much, Dr. Nikema and Elodie, for that very useful response. I hope it was useful to hear some of these risks. I actually had not thought of them, that they could be, these type of risks could come up unexpectedly. So my next question is to my colleagues in Bangladesh. As I stated before, you used vouchers. And so I guess the question is related to why vouchers was a better option than, for instance, other demand side financing. Particularly, can you elaborate on the pros and cons of using vouchers and then capping it at a certain amount? I didn't state this earlier during the case study slide, but so in Bangladesh, each organization capped the amount to a certain amount so that people don't overspend within that amount. So can you say more about that, please?
Yeah. Okay, maybe let me start once again. So while we are talking about vouchers, so how this voucher is being translated by our beneficiaries. So if you think about a card like this ID card or any kind of card, so it's kind of rights. So this voucher, be it card or any kind of basis, so it's ensuring the rights. It's the health rights, it's their social rights, and this entitlement is ensuring their power as well. So we have seen when we were distributing the card, and they went to the facilities to really take the services. Initially, they did not really fully understood and full confidence actually that whether they will get the services when they will go to the private sector facilities or others. But when they got the services with that card, and they did not have to pay anything, so they were huge empowerment side by side when they were sharing this experience to their peer or their other neighbors. So it got actually a community confidence. So that's why, I mean, it's very, very important while we are talking about voucher, it's their rights. We are basically helping to ensure their rights are well taken care of, number one. Number two is your second questions about whether it would be closed or it would be open. This is again very, very important to understand the philosophy of this health voucher scheme. What is the philosophy? If you ensure the equity, so it has to be open. Or if you have very limited amount of budget and you would like to cover maximum, so definitely you cannot make it open. So maybe one or few people will use it maximum due to their catastrophic cost and expenditures, and others may need some primary healthcare services like fever, cough, and kind of thing. So to ensure the equity, it has to be actually, you have got some ceiling over there. Now, otherwise you cannot manage. From management point of view and from rights point of view, it is very, very important that we are ensuring all these needs. Because why we are implementing this project? Because their needs were not well taken care of, not by the state or not by the other service providers. So urban extreme poor, this is the entitlement, this is the right, and this is also ensuring the equity. I'll stop here and I'll request our colleagues from RIC and DAM to add more from their experience. Thank you. Thank you, Yasmin.
Actually, considering the limitation of the resource, voucher is more appropriate, which already mentioned. So we always suggested the vouchers, but obviously for point of equity, the open-ended is, but considering the limited resource, voucher is fine, and voucher is must, I think. And other things, the minimize the risk. Second question, maybe minimize the risks. So we can ensure the we can strengthen the monitoring within ensuring the quality management visit. And we are already introducing the complaint response management systems. Both of three organizations have these sorts of opportunity and these sorts of option. We have already hotline. There are two types of hotline dams in already working. Area which there are hotlines, and in the central office there is also a number, designated number. People can complain at any time if there are any kinds of discrepancy. So if we ensure the monitoring and strengthen the monitoring and quality assurance teams visit are regular, and if their suggestions are in place, then it will be work very good. But before that, we have to ensure that these sorts of mechanisms are in place, and these are implementing accordingly. On the other hand, the local authorities must be engaged in every phases of the project implementation, from the very beginning of the beneficiary selection and the service providing. So if local government authority ensure their participation, then it will be very fruitful. Thank you very much.
Thank you, Dr. Nasser. Would you like to add anything?
I can add something. This is our voucher card that we provide to the poor families. About cons, firstly, we have faces a few problems to introduce this to the beneficiary or from the poor household. We work with the population at community level by dividing them in health group. We award them through health group meeting about the card and how they taking services from the clinics, and we create one community volunteer from each group. They help to mobilize the people when they sick or need require treatment from the clinics. Another thing is that the Mukhlesh Bhai from Bangladesh mentioned rightly. We are arranged to engage all the municipal authorities and government line department from health and family planning, along with the NGO representative. We arrange a joint visit to each of every clinic for monitoring the quality of services, and also we taking interview the users about their satisfaction through using a format in clinics and also in community level. So we are not faces huge problem. I think it is okay, and voucher program is very successful for the community poor people at urban Bangladesh, I think. Thank you very much.
Yasmin, if you allow me to add two more very important points here. One is while we are talking about this complaint response mechanism, so oftentimes we design, it's like a typical donor-driven project. So they need a suggestions or a complaint box, or they need a number. But when you see this becomes also another instrument so that the quality of services can be improved. And most importantly, their identity has to be not open. So when they think that they are not identified, so they can create the right complaint, and accordingly the service quality improves. This is very, very important. And you can introduce it via any hotline numbers if the mobile phones like the country in Bangladesh. So you have got more than 90% mobile penetration rate. So you can easily give a hotline number, and that hotline number, they can feedback their responses and also the complaint accordingly. Another very important aspect is how do you see this kind of voucher-based mechanism as a social safety net measures? So oftentimes, I mean, you are seeing or comparing it health as a product, and you are just ending up with doctors and patient relationship. But if you think about the situation like COVID, where we are in, I mean, despite having this very robust health system, so you are ending up, you are completely vulnerable with this kind of situation. So if you don't embed this kind of voucher mechanism into social safety net, then you will be ending up with a project approach, and it will not be taken care of by the government in the long run. So government social safety net will be continued, but it needs to be looked at into health as a social safety net components as well. So I would like to raise my voice very, very clearly that it's no more only just health services. We're talking about social safety net coverage by this voucher-based mechanism. Thank you very much.
Thank you for bringing that up. We're actually also trying to look at more ways of linking health with the discussion on social protection, because as you said, they're very much linked, and so therefore should not be separate. And then my final question, and I apologize because we probably will not have a lot of time to go to the questions from the participants, but we hope to find other ways to respond to those questions and post them to the site, or we'll find different ways to respond to some of those. So my final question is for Lou from MEDAIR. So the case study from MEDAIR is the only one that is related to emergency and related to humanitarian intervention. So how do we go? So, and this is a discussion that I'm having with health cluster coordinators and cash working groups. What is the next step? What would you recommend the next step being is to systematically include CVA and health in HRP, or how to include it in some of the cash working group discussions to include health within their expenditure survey, for instance. How do we make sure that it's included in the overall humanitarian response?
Well, thank you, Yasmin. So it's a question we grapple with a lot in MEDAIR. We're working with the UNHCR quite closely, and so we have a lot of these conversations kind of internally about next steps, particularly with any humanitarian response around exit planning and strategy around how do we leave, which of course is the aim of a humanitarian actor, to hand over to local actors and development actors as well. In the current context, it's still unclear. There are various ideas about how we could transition out of cash for health, but ultimately it comes down to policy level decisions around making sure that there is coverage until there are returns to Syria and to other countries where refugees are residing in Jordan. The reality remains that people have a financial barrier to access healthcare. So ensuring on a policy level that there is access to healthcare has made some strides in recent times in terms of the multi-donor account in Jordan, which is very specific to Jordan, and inclusion of non-Syrians in cash for health provisions and primary health provisions in particular. But in terms of where we go as a humanitarian actor, there are different modalities to look at in terms of kind of insurance modules and various other bits and pieces. I'm aware that to the wider group still on this call, there's quite a lot of context that's needed in Jordan to explain that. And so I won't go into that now because we don't have time. But in terms of ensuring that there is continued funding for Cash for Health in the Jordan context and in other contexts, yes, of course, inclusion in HRPs and making sure that it's on the agenda is a key one. We have some really fantastic donors that support our work and recognise that that it is a health response, then cash is the modality for that. It isn't a CVA response. CVA itself isn't the sector. Health is the sector, and this is the mechanism that we use, and we adapt our mechanism depending. So I saw there was a lot of questions in the Q&A about how do you ensure that people still access quality care? How do you ensure that there isn't kind of diversion and that people aren't spending funds on other things? And we have multiple different mechanisms for that, dependent on nationality, dependent on transfer mechanism, and kind of just going back a step to the risks that other people have been talking about in their contexts, really understanding those risks. So understanding that, you know, you've got vulnerable households who, if you give them 300 JOD to access the cesarean section, for example, a medically advised cesarean section, I might add, that they might use that to meet other basic needs, like paying off debts, rent, whatever it might be. So we actually have a conditional restricted approach, whereby, for example, we pay hospitals direct for the care that individuals have received. So other than in cases of normal vaginal delivery, where it's a set rate at MOH, we don't generally pay upfront for care. There's also another exception for NCD treatment, but there are certain nuances that have to be understood about the type of care that we're giving, and also the nationality of that beneficiary, to ensure that we are able to kind of bridge those risks. And that's something that needs to be understood more widely when we talk about cash for health. It isn't a conditional, unrestricted approach that we adopt. And it requires a lot more manpower and woman power behind that to ensure that we have the right mechanisms in place and that we can address those risks. But also that at that kind of more policy level, that there is an understanding that this is cash for health, that this is about health outcomes. This isn't just about cash assistance that we hope people will spend on healthcare as well. And it's been that has been successful in terms of keeping the Cash for Health project running in Jordan so far for Medair. Yeah, I'm not sure if that answered your question, Yasmin. I kind of went through a few things there. Let me know if not.
No, thank you. I mean, I think we all grapple with this question, particularly those of us working in the humanitarian field, and it's something that I think, yeah, I mean, you're absolutely right. It takes policy change and conversations with donors and different stakeholders to make sure that, you know, health and CVA are discussed and brought up. So we don't have a lot of time. We have 10 more minutes. So a lot of the questions that we received are related to quality, assessing quality of services, and how to ensure that people, particularly when it's unconditional cash, are seeking treatment of quality services and not necessarily using places of poor quality, like pharmacies that don't have necessarily good quality medicines, or hospitals of poor quality. And so the Bangladesh case study, that's why there was vouchers. So you know where beneficiaries are going. You can ensure that they're using quality services. But in the case of where it's cash, for instance, multi-purpose cash or unconditional cash, and yeah, I guess unconditional cash, how would you ensure quality of treatment, both for receiving treatment, but also quality of medicines?
From Bangladesh experience, actually, what we have seen, we did not see the quality as a separate event, but what we try to encourage, so quality should be coming from different perspective. So it's the service provider responsibility first. So that kind of, so it can start like, I mean, 5S approach or self-evaluations approach. So there are many models are available. So first one is goes with the service providers, and you cannot really give them just one responsibility that they will be taking care of all services. So without monitoring, it will not happen. And who is going to monitor? So since we are considering it's a health system strengthening approach, so government is also major player over there. So they are the influential stakeholders. So with the government system, so as we have provided services with all these private sectors, sometimes government feels not responsible. But from our 3 different cases, we tried to bring the government, hey, I mean, this is the service providers. They are providing services within your territory. So it cannot be only their responsibilities to ensure the quality and maintaining the standard. So government was coming to monitor their services on a regular basis. So, and also, while we are sharing these experiences with all these stakeholders together, then it becomes open. So, I mean, service provider A is open to service provider B, service provider B is open to service provider C. So they all are seeing that this is the quality standards they are maintaining and what is the expectations are coming from the government and also community, that also creating some or enabling some processes by themselves. So my last message is you cannot really solve the quality problem by looking at only services. So it's a systematic problem, and you have to ensure the system is functioning holistically, not separately. Yeah.
Of course, and as I noted earlier as well, there's evidence that CVA can create competition among service providers.
Right.
So if one hospital or one pharmacy is receiving a contract from the humanitarian agency, they will compete to provide better services so they can receive it. Lou, do you mind just saying a couple of things with regards to the Jordan case study? Because I know you provided unconditional cash transfer to pregnant women. How did you ensure that they are going to quality, using quality services, hospitals?
Sure. So we actually adopt a quite holistic approach to our health response. So we have Cash for Health in conjunction with community health programming. So actually we identify our Cash for Health cases through a network of community health volunteers who are well trained. We also have health officers and senior health officers who are pharmacists, nurses and doctors. And they train the community health volunteers to go out and find not only deliver community health messaging, but also to find cases in need of cash for health assistance. It's actually through mechanisms around behaviour change and communication that we are communicating with beneficiaries. And obviously, again, it depends on their nationality as to whether or not they access MOH or private facilities. But we are able to guide them in that process and help them to access services that are known to be maybe of higher quality as well, and guide them through that process. So that is, it can't, for us, it wouldn't be a standalone cash for health approach. It is a very holistic and nuanced approach in response to wider health needs of the refugee community in urban settings. And so that's where the community health and the cash for health modules kind of come in together and work together to achieve that. Yeah, and in terms of, there was an earlier question around kind of the checks in place to ensure that people are actually in need of health assistance and the cash. How do you verify those needs, basically? And that is through, it depends on the need. If it's a medical case, it's an emergency case, then health officers will be involved in that. We also have partnerships with JPS here in Jordan, which is the Jordan Paramedic Society. So it's working as a wider kind of team. We also work very closely with UNHCR. I think a standalone cash for health project with where you don't have any of the kind of Ministry of Health structures, you don't have any of those kind of standards of care in place in a context like Jordan, where you do have standards of care in place. You don't have a UNHCR functioning alongside you to do cash for health assistance. All of these things have kind of enabled Medair's response in Cash for Health. A standalone Cash for Health project in a context that doesn't have that infrastructural support in place would be incredibly labour intensive in terms of the resources that you would require to get that up and running. So that's another kind of learning from Jordan.
Thank you so much. So unfortunately, we have run out of time. As Julia stated in the comment box, we will go through these questions and try to respond to them and hopefully either send them out by email when we send out the recording or post it on the CALP website. Julia also shared several other resources on the CALP website, including a blog CVA and diabetes, and we're also working on another blog, hopefully, in the next coming weeks. And then coming up also is a synthesis study done by CALP for the MENA region. So we have more stuff coming out related to CVA and health. So we thank you for your participation and all your questions, and I thank all the panelists for, especially colleagues in Burkina Faso and Bangladesh, for your availability and time. Hopefully this is just the beginning of more conversations around CVA and health. Julie, do you want to add anything else?
Just to say thank you very much to you, Yasmin, for all your hard work and for hosting this. And thank you very much to everybody. I really think that we have a fruitful area of learning and period of time ahead. So bye-bye and thank you very much.
Thank you.
Merci bien. Au revoir.
Thank you, everybody.
Thank you. Thank you very much. Thank you, Julia.
Thank you.
Thank you.
And thank you, everybody.